gonna give a very rushed introduction, and I'll let you fill in. I don't want to cringe anymore on your time.
Oh,
Um,
no problem.
but
I'm
thank
glad I
you.
got to jump onto your the tail of your talk.
Yeah, thank you. Um, so next up we have Dr. Wendy Oliver-Pyatt. Wendy has a medical degree. She's a medical doctor. She has her FAED, CEDS, FIAEDP. She is a leader in the healthcare mental health space as well as in the eating disorder space. She's an entrepreneur. She's a world-renowned speaker. She's an author, philanthropist, leading expert in treating eating disorders, which I already said, with over 20 years of experience. So, how she started this at the age of 5, I'm baffled by, but she just is really amazing. Wendy's the co-founder and CEO of several esteemed institutions. She's the director of Galen Hope Treatment Center, which has multiple sites in Florida, and also Within Health, which is an online health program, which is really just revolutionizing eating disorder care. And there's so much that I'm leaving out. Wendy, feel free to add anything in, but
My
so
gosh, no,
grateful to
thank you
have
so
you
much for having me
on.
here. And I'll try to make sure I'll probably just kind of zoom through parts of this to try to give a little time for Q&A.
Excellent.
Um, so anyway, thank you very much for inviting me to speak at this, your first inaugural conference. I think it's a very interesting group of people you brought together, and I especially love the attention to the psychedelics in treatment, and I love also that you're paying attention to Buddhism and infusion of Buddhist principles into care. I think that I've always had some of that in me. And I think that the mindfulness, I mean, I just think it adds so much. So we don't get to talk about it. We don't see it a
Yeah.
lot in our conferences that we go to. So why I really wanted to do a talk like this is one reason is that I wanted to kind of think about where the field has been and where it is now. I remember I was on a Facebook um, group and somebody asked like, "Oh, are there any health at every size providers in whatever state it was?" And all these people are like, I am. And everybody was just sort of jumping on and saying that they were health at every size providers. And I was so happy. I was like, oh my gosh, look at how that is. Because when we first brought those principles out more assertively into the field through the Binge Eating Disorder Association, we were met with a lot of not just eyeball rolling, but like you're crazy. Was kind of like the mindset. Like those are like the crazies that are just trying to tell people in large bodies it's okay to be who you are, which is part of the principle of every size of health at every size, that you actually are lovable as is, and acceptance is like a key to health and healing. But that was treated as something wrong to convey, largely. And so it's been a nice progression for me to see now, like when I was on that Facebook post, seeing all the excitement about it from folks within the field, whereas before we took some punches for it. So that just gave me the idea of like, wow, there's been so many changes in the field since I began my work in 2000-ish, that I wanted to kind of highlight that, and in so doing, um, kind of invite us to remind ourselves that whatever we think is the truth and the fact and the way it is, like whatever we hold on to because of like we think of evidence-based treatment in this very like very confined way and leave out clinical experience and lived experience a lot of time, but that's changed. But whatever we think at any given day and time about this field or our work, it's evolving all the time. So let's not get stuck on any ideas, because it made me realize in these 25 years ish how much our thinking has evolved. So I wanted to talk about that. But then as this talk kind of evolved in my own mind, I also wanted to introduce some of the newer concepts that I see entering the field that weren't there when I was beginning and that have kind of come about. And so we'll talk a little bit about those things like what is severe and enduring, what is harm reduction, what is trauma informed, and things of that nature. What is anti-carceral movement, and why did those things come to be, and how are they affecting patients in the field right now? And then if you want to call it wisdom, you can call it wisdom, or you could just call it what I happen to think today, which may or may not be wise. So we're calling it wisdom, but that's up to the audience to decide. But it's just kind of like where how I'm thinking about things right now to share for whatever good it may be, whatever may whatever benefit that may have. I think it's really cool to reflect upon Hilda Bruch. She was really a pioneer in using the biopsychosocial model. So other people had actually come up with the construct of biopsychosocial, but it wasn't like really getting used widely. But Hilda started to really, she was a Jewish psychiatrist from Germany that fled during the Nazi era and went on to treat eating disorders. And she was able to link together in eating disorders the profound connection between the biopsychosocial realities of an eating disorder and really any condition you want to look at, diabetes, lung cancer. They all of these ailments you can like put together a framework using a biopsychosocial model. And I like to really put this out there because it allows you to leave no stone unturned. So you can think about the condition of an eating disorder from the biopsychosocial foundation as far as the etiology and also the treatment. That's like some of the things you're talking about too. And that's why we talk a lot about epigenetics and trauma and how that all is tied together. But the biopsychosocial, really, I think about as on the biological side, I think of like the physiological reality of the patient, both from the eating disorder and other physiological realities the person's going through. And also within the biological is the nutritional issues and the psychiatric, brain-based mental health conditions that are all affecting the person. The psycho on the psychosocial, I think of it as like personality traits, defense mechanisms, worldview. We see things like high harm avoidance, perfectionism on one end, and then we see executive functioning issues, sort of on the other end of the continuum, sort of everything in between. But looking at the psychosocial the psychosocial is also like all interconnected. Family dynamics, like family of origin dynamics, like the community you're in, like what kind of school you're in, what kind of religion are you a part of, or spirituality, or are you a part of? Yes, if you are, and how that's shaping you. So there's no condition like an eating disorder to like sort of make you think about things along the biopsychosocial domain. And I really thought of like the Rosa Parks quote when we were forming the Binge Eating Disorder Association, and we were taking a lot of heat for the concept of health at every size, a lot of heat. Um, and we also introduced we really shed a lot of light on weight stigma. And that was when we started the Weight Stigma Awareness Week during that time. And it wasn't widely adopted. It wasn't something people didn't think about weight stigma a lot at that time in the field. Even just like back to like maybe 2010, people weren't thinking about it. I think that all eating disorders, aside from perhaps ARFID, but the typical classic, are all fueled by weight stigma as one of the core features that's driving the condition. So as we go through this, we'll talk a little bit about some of the game changers. I'll go kind of quickly through some of this stuff because I think some of it's like kind of really tied in with what was just spoken about. But I just kind of want to point out some of these things.
Wendy, real quick, do
Mhm.
you have slides that you want us to share?
Are they not sharing?
No.
Oh my gosh.
So sorry.
That is hilarious. I'm sitting here going through my slides,
Oh no.
thinking that you guys
Yeah,
are seeing them. I was talking this whole time thinking you guys could see my slides.
got it.
Hilarious.
Just your
Thank you for
beautiful
letting me
face.
know. Okay. Here we go.
Beautiful. Thank
I
you.
wasn't even thinking, I was just rolling. Thank you.
Yeah,
Well, you missed the slides from before. I'll show you the picture of Hilda Bruch.
excellent.
There you go. That was what the slide was for Hilda. I thought she deserved that credit. All right. Thank you for that prompt. I appreciate it. I was off and running. So here's some of the things that we can talk about today, and some of them I'll move more quickly through because I think they're already getting discussed. But one thing I really love that's happening in the field right now is the breakthrough of lived experiencing actually mattering. So back in the day, folks that had lived experience, like when I was earlier career, it was when I first came into the field, like I had written a book and it had some self-disclosure in it. I was like kind of scared to release that book because I thought, what are people going to think, and would people believe that I really was free of an eating disorder if I share that I once had an eating disorder and that sort of thing. And I realized that it was kind of going back to the Rosa Parks things, like if it's true then say it, and it's true that I did have an eating disorder, and it's true that I don't have an eating disorder now, and I'm, I just don't even really think that much about food. I'm like very much released from that, thank God. But just that's my lived experience, and that lived experience actually matters now in the field. Whereas before, in the earlier part of my career, we actually hid lived experience. And we had a tendency to understand evidence solely under the premise of like, it's the research, like it's the, placebo, double-blind, placebo-controlled research. It's that or nothing. And now we have this three-legged stool of evidence that really matters, which is yes, all of that research is amazing, and let's use it, whatever we have, and lived experience and patient and clinician experience, like that all matters. What the patient prefers as modalities of care, these things actually also matter. It's not just this, very narrow definition of evidence. And why that is so very important, there's so many reasons why it's important, but a lot of times, first of all, lived experience is what actually drives research. And even if you look at Francine Shapiro with EMDR or Marshall Linehan with DBT, all of that was like originating off of lived experience. Those were where the ideas actually came from. But also doing research can't really keep up with clinical wisdom. Like it's really hard. I was doing things that would be later called acceptance and commitment therapy before I even heard of acceptance and commitment therapy, because when I was thinking about, well, how did I get better? It was like values, like that was really important to me. But later, I mean, it was kind of nice and kind of reinforcing when I did discover Steve Hayes and ACT. I was like, oh, I was doing something that, okay, cool. Like, but it was really just something I wrote on the back of an envelope one day when I was like, what are all the, I literally wrote down I wrote my first book, which was called Fed Up. I was like, what are the things that helped me get better? And it was like getting aligned with my values and thinking about the priorities in my life and what I wanted to put energy into. And so it's just interesting how clinical experience and lived experience can kind of come before all that more traditional research, and like using that is important. It doesn't mean that it should be just like a free for all though. And like it's hard though, because when you have lived experience and it's not like this more rigid way of thinking about research, it's a little harder to ensure quality control. And that's one of the things I want to talk about today in our time together is the field itself, and some of the observations that I've seen. I do give credit in this talk to some people who I think were very influential on our field, to make some of these breakthroughs and changes like happen, which was Dr. Timothy Brewerton, who I admire greatly for his steadfast conviction around assuring that trauma was a part of treatment. When I first worked in the field, we actually had to hide the fact that we were doing trauma work when we had people at higher levels of care. The insurances would tell you don't do that when you're with them. They thought it would destabilize the patient and that it should be done when they were out of the controlled or contained setting, when in fact they needed the safety and security and holding that we could provide in higher levels of care in order to do the trauma work. So that was really a mind FUCK, if you will, for patients, because they were going to treatment and clinicians were being told, like, basically don't address the core issues that are driving the eating disorder. And that was really bad for patients. And Dr. Bruton really changed the game with that. And then my dear friend and colleague, Shavis Turner, she and I are the co-founders of Weight Stigma Awareness Week, which is coming up. But she was like a real leader in our field, founding the Binge Eating Disorder Association that I was lucky enough to chair the board of that for a long time. And that's when we really helped bring BED into the DSM. She really was behind that, and the foundations of health at every size really came forward. And then the Weight Stigma Awareness Week was kind of tied into that. So that was really important. Dr. San Chang, one of many, but a really prominent clinician and researcher that brought about the more awareness about diversity and inclusion. There's others as well, but I just want to credit their book, Clinician's Guide to Gender-Affirming Care. I think the gender-affirming care wave of knowledge that we have now is way overdue. And frankly, we made a lot of mistakes. I know I made a lot of mistakes because of my ignorance here and understanding how gender issues, if you will, influence eating disorder and eating behavior, whether it might be a protective mechanism or body dysmorphia that's tied to physiological realities of your body and how that influences eating. It's a different course of treatment that's indicated in some of these cases, and certainly a deep understanding is really important. I'm actually working with a patient right now who I treated about 20 years ago for anorexia nervosa, and it's only now, 20 years later, that this person understands their aversion to weight restoration is tied with their non-binary gender identity, and that weight restoration and curves and softness and breast tissue and hips is extremely aversive. And it is not the same as the dysphoria of traditional anorexia nervosa, although this person has been diagnosed with anorexia nervosa. So understanding what is driving the condition is incredibly important. And our field has been, in places of extreme ignorance around this until more recently. And so I credit Dr. San Chang for their contribution there. And then we also don't realize that DBT was not always here. It's been a tremendous advancement to the field because DBT really was that area of psychology that finally, for once, really linked treatment modalities that were psychodynamically informed with also like behavioral strategies. And that's really been, for me, the foundation of all of my programs. And I'm glad for it. And I'm even more wed to it now than ever that good treatment really relies upon a psychodynamic, biopsychosocial foundation with a psychodynamic understanding of the evolution of the eating disorder, the functioning of the eating disorder, the protection of the eating disorder. And I do talk a little bit about self-psychology in this talk because I think it's something I use a lot, and I think it's a potential really good anchor for clinicians to understand the psychodynamics of the eating disorder and then behavioral manifestations. So I think, and how to approach those behaviors, of course, is where Dr. Linehan just like really made a huge difference, not just with eating disorders, but the entire field. Um, so these are just some of the things, that trauma had basically started to get allowed into treatment. And binge eating disorder got included. Weight stigma is like kind of now known to talk about. Health at every size is accepted. Diversity, inclusion matter. And DBT is really kind of mainstream. So I'm going to go quickly through this. I already talked a little bit about trauma, and I just wanted to mention that I think when you search into a person with an eating disorder and trauma, which about 80% of people that come to higher levels of care have trauma. So you can see the way the eating disorder behaviors and the trauma become really interconnected and like the function of the eating disorder. So the avoidance of trauma is really manifested in the avoidance in anorexia, the anorexia that is a part of all eating disorders. Note I didn't say anorexia nervosa because bulimia, anorexia nervosa, and BED all have a restricting anorexia core to them, which is rooted in shame. But also that is tied in with like emotional avoidance and numbing, the restriction of emotion and really disconnection, right? The numbing of avoidance in trauma can be kind of the mirror of that with food, or the way that's manifested with food is disconnection from appetite and hunger, which is really disconnection from the source of life, which is food, which I think is very tied in with trauma and the the manifestation of trauma that can be so overwhelming that sort of makes being in the world not even safe or wanted, or just caring and needing is so scary because it's led to trauma. And then the arousal of the eating disorder gets manifested in food, and I call it the faulty alarm system. So it's like when a person has an eating disorder, it's like the I'm fine when there's like major restriction or not nourishing your body, and then the red alert when you have a peanut butter and jelly sandwich. So it's like a faulty alarm system. And it's a manifestation of arousal from trauma coming alive in the relationship with food. And then the reliving of trauma and the way that the eating disorder just blocks everything else. I mean, it's just when you have the person has an eating disorder, like whatever trauma is underneath there is like generally buried. So as you're going through some of the eating disorder treatment, then there's more space for the trauma to emerge, which you have to be ready to catch that and see it. And it's not a linear, it could just pop up here and there. But the thinking of the eating disorder in this way that it is protective from the trauma and it takes a lot of space up. The other thing that really has changed in our field is CPTSD has come into the reality. It's not in the DSM, but it's in the ICD. And I think that's very important. It goes back to your talk about adversive childhood experiences, and it recognizes other kinds of trauma that fuel CPTSD, and that's just not to be missed in the field. And it's an advancement in the field because back in the day, I mean, I used to struggle with looking at the DSM, and I still struggle with the DSM, but looking at the DSM, and it didn't have room for what I felt was trauma because it didn't meet the DSM criteria for trauma. But when you look at CPTSD, it gives you the opportunity to see how I think one of the biggest things is childhood emotional neglect and chronic invalidation, but also just racism, oppression, bullying, all of that. And I just say also being large in a diet culture focused world, and weight stigma is a chronic trauma that folks experience, and probably one of the most prominent aspects of our of eating disorders. So it leads to disturbance in self-organization with a negative self-view, difficulty with relationships, loss of a system of meanings, emotion dysregulation, difficulty managing that. So just important to think about that. So childhood emotional neglect itself can actually lead to perfectionism, low self-esteem, emotion regulation issues, relationship challenges, trust and intimacy, emotional vulnerability, which is what we really work on when we're working on like the interpersonal. I really encourage people, you mentioned it too, Brenna, to really think about the interpersonal aspect of eating disorder, and like the relationship becomes so pivotal to the healing. And I use the foundations of self-psychology, which all of this very much overlaps. If you look at attachment therapy or interpersonal therapy or self-psychology or DBT, you're going to see all sorts of different overlaps. Um, and I believe, Brenna, you may have actually talked about epigenetics. I came on a little bit toward the end, but epigenetics is also something that we're much more. Okay, you did talk about epigenetics, so I got a thumbs
Just a
up.
teeny tiny bit. I didn't give any description. I just said the word.
Okay, okay, I'll do the 30-second or 60-second version.
Fantastic.
So, what is epigenetics? I think for we should, I don't know if people in the audience may already know it, so I'll go quick. So when I was earlier in my life, like when I went to college and medical school and everything like that, we were just taught of Darwinian genetics. So it's like survival of the fittest. It's like the DNA changes are that lean towards survival of the species are those that are more likely to be passed on over time. And evolution itself is something very, very slow that's based on DNA changes. The actual DNA, deoxyribonucleic acid, is like the sequence of amino acids that is in every single cell of our body. All cells have the same DNA sequence, but just different cells manifest different proteins that make up those various organ tissues. But my skin cells and my heart cell and my eyeball, the cells that make my eyes, it's all the same DNA, and it's a very slow progression as far as like evolution. Epigenetics is very interesting because it's really funny, actually. My daughter, I'm doing more than the 30-second version, but I get excited. Anyway, my daughter was in ninth grade and asked me, she was like, she was reading this thing in her biology book about epigenetics and she couldn't understand it. And I like got her book and I was like, what the heck is this? Because I was so inundated with like Darwinian evolution because I was a biology major. I was actually a biology and psychology major. Um, but we were inundated with that concept of Darwinian. It was like Darwinian or bust, you know? So she's reading this stuff about epigenetics in her ninth grade biology book. And I was like, what the heck is this? Well, basically, what we've figured out is that we can evolve much more quickly. Our DNA isn't necessarily changing, but things happen to our DNA in response to trauma that help our bodies survive that trauma, but also have downward effects. And I think you talked about the inflammatory process and also hyperarousal. And what actually happens is that things happen to the DNA, whereas like DNA is called methylation, or it's just basically in layman terms, it's like things getting attached to the DNA to make it behave differently. That's why it's called epi, like above the DNA. So the DNA is not changing, but things are happening to the DNA to make it behave differently, with inflammation being a big piece of like one and arousal because it's trying to make the body be ready for danger. So when you're the offspring of somebody from 9/11, or when you're the offspring of a Holocaust survivor, as I am, I can sort of count on the fact that my DNA was already changed by the fact that my father's DNA was changed. So there's so much trauma among all of us. I mean, there's just trauma is everywhere. It's almost like a health hazard of life. So there's a lot of epigenetics happening among all of us, but being kind of aware that people may have more vulnerability or drift towards the manifestations of trauma that happens in real time if they already have the epigenetic load. And I think of that during the pandemic. I think so many people that there was such an increase in mental illness during the pandemic. And I think my theory is that there was so many people already walking around with the epigenetic load, and then there was just, constant trauma happening. So there are plenty of studies that support the reality of epigenetics, and it's just something for us to keep in mind. And that's why trauma informed matters so much. I'm going to kind of bolt through a lot of this stuff because I think a lot of it was covered, and I sort of want to make sure we talk about some of the other yummy stuff and give a little time for Q&A too. Just really quick, I wanted to mention another breakthrough in our field, which is EMDR. And again, this was also lived experience informed by Francine Shapiro. She doesn't really get a lot of credit for that, but when we are talking about trauma, I think EMDR is still quite underutilized. It is truly an evidence-based treatment. And so for people with eating disorders of any sort who are having a struggle with recovery, I think it's important to look for the potential trauma, as you said, not who you are, but what happened to you, right, Renee? And then really just making sure we're considering all options for treatment, and not forgetting EMDR. It's a very effective modality of care for trauma, and I think is important to have in our back pocket as a potential modality of care for people who are, quote, treatment resistant. And so I don't think that treatment people are treatment resistant. I think alternatively that treatment Instead of people failing treatment, treatment fails people. And there isn't a patient that I've ever treated in these years that maybe had in and out of treatment a lot or whatever, and I could just like get their history, look everything over, and after a while, it doesn't take really that long if you use a biopsychosocial model or biopsychosocial spiritual model, and you can see the holes in treatment. It's like, oh, they never got trauma treatment, or oh, they never really had good family therapy, or oh, they never really did exposure therapy, or oh, their psychiatric diagnosis is wrong and they never really got the right treatment. Oh, they always left treatment prematurely because the insurance cut out, or oh, they kept going back to the same systemic situation that was fueling the condition. Because again, going back to what you said too, Brenna, that at the core, there's this, if you will, healthy self that's kind of wanting to emerge. It's bred from the essence of who we are. But these variables out there and inward may not have been fully addressed. So again, just all due respect to Francine Shapiro, and it was her own lived experience. She was walking through a park and gazing left and right in the park and noticed it attenuated her anxiety. She had some of her own trauma because her sister had cancer. And I don't know all the details with that, but that's something I read about. But she actually developed EMDR based on that walk in the park. I think you're spending time here talking about trauma in this conference, which is very progressive of you. And what I think is so cool about the psychedelics and understanding them is like I actually think it goes right back into this concept of essence and the psychedelic experience. One thing that allows for, in addition to the plasticity and sort of rewiring of the brain in the ways that the brain is sort of stuck, if you will, on a psychological plane, the experience when you speak with people and understand it a little bit is really it's like really bringing up compassion. It's really bringing love into the equation and like generosity of spirit and love really are what is like really healing for people going through these types of experiences. Having more self-compassion or having more compassion for others is a big piece of it, which is something we've talked about for so long, compassion being a core in the psychedelic experiences. One of the themes when you talk with folks that is what they talk about is just the feeling of compassion for themselves, compassion for others, and generosity of spirit, I'll say. Um, I won't necessarily get into this, but I think it's important just kind of say, since we're all together, like let's like leave it more in the forefront of our mind when we're dealing with somebody who's struggling, just like I was saying with EMDR. It's a modality of care that is incredibly powerful for some patients. Lived experience we've already talked about. I want to bring up a couple of other concepts that have emerged in the field more recently and share some perspective on that. So the field now more recently has been, you hear the language, this wasn't previously discussed much in the field, but you hear the concept of harm reduction. And I think it's created a little bit of confusion in our field because yes, I am all about harm reduction. And we have to be really careful, and we'll talk about anti-carceral movement too, but we have to be really careful about harm reduction versus attenuating boundaries to help people recover. Like how do you navigate that with a patient? It requires a tremendous amount of like fluidity and thought and openness. There's this quote that Susan David, she does a lot of work on resiliency. And so one of her quotes that I love is that rigidity in the face of complexity is toxic. I don't know if you've ever heard that quote of hers or not. I absolutely love it. So we a lot of times overly protocolized treatments really don't address like what is actually happening with any one person that walks in your door. And sometimes people kind of go each direction. Like you hear people that say, "Oh, I'm holding boundaries. I'm going to hold the boundary and tell the patient I'm not going to work with them if they don't do blah blah blah. I'm holding the boundary." And there's a sort of sometimes a moral superiority that people seem to get into their mind when they're like holding the boundary. And then the therapist over there, which is my personality, is, well, wait a minute, I'm not gonna quite do that, and maybe I will do this back bend, cartwheel, or flip for this patient. Um, and in the past, it's interesting because in the past there was a sort of moral superiority around holding boundaries that you could feel in the field. And then if you were like kind of breaking boundaries, you were like breaking boundaries and being the weak link in the treatment, right? And so it's been kind of an interesting thing now with harm reduction. It's cool because you get permission to do the backflips and the cartwheels, that so often the teams that I work with and lead at Galen Hope and within, and they know me, and thank God they put up with me. But it's like, yeah, we're gonna do that. Yeah, we're gonna do that flip, or no, we're gonna make that exception because that's what the patient, I think, needs. So harm reduction does honor autonomy. It reduces shame, increases trust, but it also has a risk of lowering the bar of like what your expectations are for the person's healing process. So attuned boundaries do create safety, encourage accountability, build structure. But I think what's also important about attuned boundaries is it demonstrates believing in the patient. So there's no one-stop shopping here. This is two things for us to think about. And I think what I'm liking now in the field is I'm liking the added concept of harm reduction because it's allowing clinicians to work more flexibly with patients rather than just saying, oh, they're not going to do what I said, screw them, they're not coming to my care. I remember when I got my first call from Dr. Sean Rebal at Within about our first patient that wanted to admit who was on GLP-1. He was like, what are we going to do? Are we going to admit, because philosophically we were like, eating disorder, GLP-1, not a great combo. Are we just going to say, nope, you gotta be off of that. Within's not admitting you. Too bad, so sad. And we said, no, we have to rise to the occasion. This is the reality of what our patients are experiencing. It's what they're being told to do. Some of them feel like it's improved their quality of life. We can't just like negate that. So that was me being nimble and not rigid. And so that's something to just think about. It's sort of a balancing act. Then the other thing that came up was the concept of severe and enduring. Um, so I'm sure people in this audience have heard about this. Now, this was not even anything that I had even heard about at all until just, gosh, probably 5 years ago, maybe. It was not even a concept that was talked about in our field, just not that long ago. What I worry about a few things with this. I worry about newer clinicians coming into the field and hearing about this and just thinking it's like this thing that exists. And oh yeah, by the way, the criteria was at least two treatments. Like, are you serious? Like severe and enduring after two treatments? Like, I can't tell you how many patients I've treated that have had over 10, over 15 treatments that got better. Um, so I don't like I don't like that definition like at all. But every one of these constructs that's come out, it comes out of a need. Like there's people that have worked with people who suffer greatly, who believe for their own humanistic reasons that this concept is important, and moving people through treatment with this in mind is more about just reducing their pain and suffering versus aiming for recovery. For me personally, I'm an aim for recovery gal. Like that's just who I am, and that's what I believe in. I do believe that people can heal, going back to what Brenna said. But I think each person deserves their own approach and thoughtfulness, and we all have to, I think, get true to what's ever in our heart as clinicians about how we want to sort of balance this concept in our own treatment. I did have a patient that got referred to us again, this was a within referral, and this clinician referred the clinician was pretty new to the field. The patient was like 23 years old, and the clinician contacted our team and said, "This is a severe and enduring patient. We don't want to do weight restoration. Just can you leave him on this lower calorie thing?" And in that case, like I didn't accept that patient. I was like, I wanted to explain to the person why, but that just violated my principles, and I didn't feel like she had had enough of a course of treatment. But of course, that left her where she was at, which I sort of regretted. But the problem that would have happened in that case is that if the outpatient provider and myself and our team were going to be misaligned, it was just not going to be helpful. And I do feel bad. I do have some conflicts about that in my own mind because I'm like, well, that was her experience and that. But anyway, that's just, but I just wanted to put it out there that this concept of severe and enduring has not been around for a really long time. There is controversy about how you define it, and it can leave people really without us holding the bar to their, recovery. And there's a lot of things that can really influence whether or not the person's actually gotten like a real fair experience of treatment. And if we don't pay attention to these principles, then we could say they're severe and enduring, but they might not have actually just got enough treatment. And these are all things that we see. And yes, sometimes it's underqualified providers that don't understand like how to actually treat some of these conditions. And the conditions are really hard to treat. I mean, I've worked with people that I certainly feel like I understood them, but I that wasn't even enough either. So there are people that just you do get stuck and you haven't been able to help. I've had those too. So I'm underqualified in that regard too. So I'm not saying anybody's over more qualified or but I was like in certain cases I couldn't get that home run with them. And so I was underqualified, but I still believe that person has a healthy self somewhere in there. One of the things that I think has also been in the field that's good what I like, but I think it's a real balancing act, and I've seen it fall very short in our field, and that's where the concept of treatment traumas come in. So, I just call it the paradigm is from compliance to connection. So I've seen an evolution. I've seen like the field go a lot of different directions. But there was sort of this like symptom eradication kind of approach, which kind of bothered me because I think of a symptom as an opportunity rather than just something you get rid of. But it was like it's about compliance, follow the rules. And this is very protocolized treatment, if you will. And now I see more of this awareness about humanism and trauma-informed care, harm reduction, and moving in the direction of authentic connection. And that also includes weight inclusive and anti-stigma framework. So I've seen this in the field, but at the same time, I've also seen a field that's had a lot of trouble, particularly at the higher levels of care, of manifesting that in higher levels of care. And I think it's very important when people I mean, getting people into the right level of care is one of the most important things. I always teach that to psychiatrists. Like, when I used to teach them, like, most important thing decision you're going to make is does a person need to be in a hospital or do they need to be an outpatient? Do they need an intake? Like, knowing what level of care people need is very important. But one of the problems we've seen is that the programs themselves sometimes are really struggling to deliver the care, or it's not principled, or it's understaffed, or the staff's very young. So that's created this awareness too of what carceral care is. So just a little bit about this. I was really thinking more about this because of Molly Gwen, who gave a talk at Meta, and I'm lucky enough to have this brilliant PhD student that works with us at Galen Ho, but she's just really been demonstrating tremendous thought leadership. And she gave a talk about this at Meta, so I credit her for me even thinking to talk about this. But she brought up, and I've heard it too, this whole concept of anti-carceral care is like my patient's looking for anti-carceral care. How do we draw that line? Oops, how do we draw that line between what we're going to call anti-carceral care and also holding boundaries, loving boundaries, for patients in order to actually get better? Because these are conditions that we treat oftentimes that are ego syntonic. They're conditions that align with the ego state or disorders of the self and the conditions functioning in some way for the person. So they don't come into our spaces and say, get rid of my eating disorder. So if at the same time, I think there is that core essence of that every person walks in our doors is carrying, that's also hoping we'll believe in them and hoping we will hold them and hold them accountable and give them the steps or the framework to healing. May not be that they, go from here to here in 30 days or 60 days, the way insurance companies or some of us may want them to, but it's that yin yang, if you will, between holding the boundary and creating that treatment plan versus like this anti-carceral concept. So it's a very interesting dilemma that we face to create the compassionate healing process and hold the boundaries, which may feel like punishment to the patient, may feel very, very scary to the patient, holding the boundaries around, for example, things like families making the decision that they're not going to pay for college, but they're going to only pay for treatment, things of that nature. So I think one of the ways that I like to think of how we kind of approach that is I use a lot of like natural consequences. So what we do in our care, we try not to create the way I design care, the way I want our teams to design care, is based on natural consequences. So it's not carceral or punitive, it's natural consequences. So for example, we don't have a policy that if the person doesn't complete their meals, they can't use the phone. Like that is disconnected. It's not a natural consequence. It's an artificial consequence, which one could say that is punishment. But a natural consequence is saying the person didn't complete their meals. So when we're going on the nature outing and we're walking, we're going for a trail walk, no, I'm sorry, you didn't complete your meals, like you don't have adequate nourishment. That's a natural consequence. So that's not punitive. That's using reality to help the person like understand where they're at and how the condition is affecting their physiological like reality. And it really allows for a developmental process as well. I do think that if we ignore there's a problem if we put out artificial consequences, like I was telling you, taking away the phone if you don't eat, or no, you can't visit your family because you didn't eat. Those kind of things, that's punitive and carceral in my mind. But if you use natural consequence, if you ignore natural consequences, that's also an injustice to the healing process. So if you're a provider and the person's like dropping weight, or binging and purging, and you're just thinking, gosh, my therapy is so good. I'm just going to keep doing this outpatient, right? I see that a lot. It's like, guys, like people are sometimes really out of control of their behavior. And I have one of my story, I had this therapy session. Was like a light bulb moment for me. I was having a therapy session with this patient, last session of the day. I thought I was a really good therapist. I was like, I have such a good relationship with this patient. I just love her. We're just getting so far. It's so deep. We're really touching on so many important things. And I was literally thinking, I was like, wow, this is such a great therapy session. I love it. I love this work, all that stuff I was experiencing. It was the last session of the day, like I said. Anyway, I had to go stop for gas on my way home. And the patient had left a few minutes before me. Well, as I'm pumping in my gas in my car, the patient was walking out of like the little mini mart at the gas station because she had bulimia and she was binging. She literally went straight from my amazing session to pick up her binge food to binge and purge. So we need to be humble and recognize when things are not helping our patients. And so it's a balancing act, but I think because there's been a lot of mistrust of higher levels of care, because there actually has been treatment trauma more in the field, so that's causing clinicians, understandably, to be really wary. And so it's just really a balancing act and figuring it out and really being very, I do think I'm opinionated, obviously, because I've done this a long time, but I think keeping people at lower levels of care when they're not prospering is like really not right and fair, and that's our job. But at the same time, protecting them from carceral programs that don't understand some of these concepts, that's also essential. So it's very tricky. it's a very, very tricky area. So I just talk about it as like compassionate boundaries, and that's sort of the yin yang. I do like using the interpersonal piece with this and really explaining to people how it's feeling for you when they're suffering, like having them understand that they matter to you and the feelings you have as you're seeing them suffer, which is a part of like the interpersonal experience and process. But that's something that's very, very important. Um, so anyway, let me just keep going because I only have 3 minutes. Oh my gosh. Ba, ba, ba. Self-psychology is a wonderful tool to help people understand what's happening with their patient and how the interpersonal aspect can come alive in the relationship and help people heal. And Kohut came up with self-psychology following the Freudian blank slate era. And he was the person that really said, hey, actually, the relationship matters. And this relationship I'm having with this person is actually fulfilling what he called self-object needs. And so he talked about the main self-object needs, but there was many, is mirroring, idealization, and twinship. And those needs are fulfilled through the relationship with caretakers. Mirroring is to be feeling seen and validated. Idealization is like there's a other source of strength around me, holding me and soothing me and comforting. And twinship is sort of a belonging to feel human among humans. And through the relationships with those caretakers, the sort of plumbing for this becomes alive within ourselves. And when these needs are unmet, this is where the disorder of the self comes in, and that the eating disorder behaviors are sort of a desperate attempt to ward off the negative feelings of the self-object needs not being met. And when you can really, I use it personally to help me understand the psychodynamics of what's happening, and it helps me understand my role in the healing, and it really dovetails very much with attachment theory and interpersonal, but it really helps me. And then, my models of care incorporate like a psychodynamic formulation with behavioral strategies and expectations that kind of link that, and they have to be linked together. I think if you only go psychodynamic, you're going to sit around and talk about the eating disorder for a long time and see your patient buying binge food at the gas station after your session, which is not really cool. But if you just go harsh on the behavioral, like come in, do it, that's it, that you're really doing another disservice to the patient and probably causing some treatment trauma potentially. So seeing the relationship as medicine. So this is really where treatment trauma has come up as a concept, because some of the programs, as I say, it's like a school that has desks and chairs and playgrounds and libraries and all of that, but there's no soul or no core or no philosophical anchor to what's helping these programs evolve. And a lot of clinicians coming in and out of the programs, and they don't get training or supervision. This is really something that's very prominent in our field, and it has led to treatment trauma. We talk more about that a lot. So anyway, I don't want to go past my time. I'm super excited that this conference has come to play, because I do really believe that some of the Buddhism things that you're bringing up here in this conference are very, very helpful to the foundation of good treatment, and really added tools to bring into our our toolbox to help anchor folks in their treatment process. It is through nurturing connection the self grows, evolves, and thrives. There's been other breakthroughs in remote treatment. We do now know that enhanced PHP, IOP, we can work even with very, very sick patients that otherwise might need to go to residential programs, and that's something we've been able to do. And our outcomes show that even very, very compromised sick patients in this enhanced model, it's not just typical care. It involves nursing and meal support and exposure therapy. And, it's a very comprehensive way of approaching this, but that we're seeing. And I always credit the patients. It's the patients that are doing the work. But we now see that what I didn't think was possible, that it's the patients doing the work. They're showing up and they're coming into care, and they're doing the exposure therapy and doing family therapy and all the things that are done in a very intensive way. I don't believe that just any virtual care works. I am opinionated about it. I'm very opinionated about exposure therapy happening. I'm very opinionated about people in treatment doing exposure work with the food and people not just being expected to bring their own food and how we manage that. But what we have seen is that even in an acute population, we've been able to really help people recover in the home environment. Doesn't mean that everybody recovers in the home environment. I also have a brick and mortar program, which we also treat people there, and there's a lot of good brick and mortar treatment, obviously, out there as well. But it's not necessarily a superior modality of care. It depends on the person. I will go ahead and stop now so that you guys can continue with your wonderful presentations today. I know there's many more to come. Thank you guys for having me. Appreciate it so much.
Wendy, thank you so much. Yeah, just so grateful for everything that you do and for sharing. It's really a blessing and a treat. Thank you.
Oh, thank you for having me and thank you for the comments. Alexis, thank you. Appreciate you guys so much. Take care, everybody.
There's a few, we're streaming on our Facebook group and
Okay.
there's a few comments there and I can share them with you, but if anyone wants to get a hold of you, what would be a good way to do that?
Just email me, Wendy at wendyoliverpyatt.com.
Perfect. Thank you.
Thank you
And
guys so much.
I
Or
can put that in the
Wendy at GalenHope.com, Wendy at withinhealth.com, or Wendy at
Wendy
Wendy Oliver.
Oliver.
Whichever one sticks in your brain more readily. I'd love to hear from you, and I'm
Excellent.
so grateful that you invited me to participate in your wonderful conference.
Excellent. Thank you so much.
All
I'll
right.
just, oh,
Oh, should I
uh,
stay on or for you said there was some I just didn't want to go into should I stay on for questions or
yeah, maybe stay on for a little bit and I can share with you some of the comments. I loved what you said, seeing the relationship as medicine. And I think that might kind of tie really nicely into our next kind of couple of talks here. So